Good afternoon and happy Sunday, everyone. Thank you so much for joining us today for our first AMSA Town Hall in a series of regular town halls we're hosting throughout the year. My name is Ali Bukhari, and I'm serving as your president of the American Medical Student Association. I'd like to take a moment to welcome you all, whether you're joining by Zoom or viewing this town hall live on Facebook or YouTube on our website. And a special welcome to our three speakers here today, who we'll introduce in just a moment. The theme of today's town hall is the power in student advocacy, where we'll be exploring access to care, health equity, and reproductive justice in the age of the COVID-19 pandemic. So this town hall today intersects with a couple of important events. This week on July 30th marks the 55th anniversary of the passage of Medicare and Medicaid. This is when in 1965, President Johnson signed those programs into law. And that ceremony took place at the Truman Library, and the first enrollee for Medicare was President Truman himself, because it was in commemoration of him being the first president to propose a national health insurance program in 1945. And since then, Medicare and Medicaid has helped tens of millions of Americans live longer and healthier lives. And also since then, the landscape of US healthcare has changed with the passage of landmark programs like the Children Health Insurance Program and the ACA, but also some of those continued challenges to these programs, whether it's Medicaid funding or the current ACA Supreme Court case, and more broadly, millions of Americans still not having access to quality and affordable healthcare. Also today, the late Congressman John Lewis, he was a lion of American history and of the Civil Rights Movement, made his last trip across the Edmund Pettus Bridge today. I know many of us here were watching that. And then finally today also marks the 30th anniversary of the passage of the American Disabilities Act. So that would like to take a moment to introduce our three speakers here before we turn it over to them. First today, we're joined by Dr. Kavita Patel. Dr. Patel is a non-resident fellow at the Brookings Institution and is an advisor to the Bipartisan Policy Center. And she's a member of the Health and Human Services Physician-Focused Payment Model Technical Advisory Committee. She's a primary care physician in Washington, D.C., and she served in the Obama administration as director for the policy of Office of Intergovernmental Affairs and Public Engagement in the White House. As a senior aide to President Obama's senior advisor, Valerie Jarrett, Dr. Patel played a critical role in policy development and evaluation of policy initiatives connected to health reform, financial regulatory reform, and economic recovery issues. Dr. Patel is also has a deep understanding of Capitol Hill from her time spent there on the late Senator Edward Kennedy's staff. She was a deputy staff director on health and was on the senior staff of the Senate Committee on Health, Education, Labor, and Pensions under Senator Kennedy's leadership. She has extensive research and clinical background, and having worked as a researcher at the RAND Corporation and as a practicing physician in both California and Oregon. And she currently advises on healthcare technology and serves organizations through the New Enterprise Associates. She earned her degree from the University of Texas Health Science Center and her master's in public health from the University of California, Los Angeles. Dr. Patel is also a former AMSA national president. Thank you so much for joining us here, Dr. Patel. We also have with us here Dr. Tracy Henry. Dr. Henry is a general internist in the Division of General Medicine and Geriatrics, and she's an attending physician for the inpatient teaching services at GRADY Memorial Hospital and assistant health director and supervising attendant in the primary care center. Dr. Henry is also an assistant professor at Emory University and holds an employment at Georgia State University School of Public Health. Dr. Henry's teaching and research interests include health policy, quality improvement, and patient safety, and her health disparities and integrating behavioral and mental health into primary care. Dr. Henry graduated from Georgetown University School of Medicine and earned her master's in public health from Johns Hopkins Bloomberg School of Public Health. She is also an AMSA national leader and served on the board of regional directors and on the AMSA national action committees. And finally, today we also have Dr. Aliyah Runyon, who is currently serving as AMSA's reproductive health strategist. She too is a former AMSA education and research fellow. Dr. Runyon attended the University of Miami School of Medicine and spent a year as a research fellow at the National Institutes of Health in Bethesda, Maryland. After graduating medical school, she served in her capacity with AMSA as that education research fellow, and then went on to residency in OB-GYN at Wayne State University in the Detroit Medical Center. Currently, she's working clinically in family planning, gynecology in Westchester County and Queens, New York. And she's involved in the intersections of reproductive health, rights, and education, all areas that she is most passionate about. With that, we'll start off here with our first speaker here, Dr. Patel. I'll turn it over to you.
Thanks so much, Ali. And I want to thank everyone for joining. I did not do slides only because every time I try, Ali asked me and AMSA asked me to talk about kind of a couple of big themes, access, COVID, thinking about kind of the legacy that we're honoring today in John Lewis for his fight for access on so many fronts. And so every time I kind of thought about putting something on slides, the numbers change, or we shattered another record with COVID, like not in a good way. And I don't think anybody here needs me to tell them that. So I just wanted to kind of offer several insights that hopefully will kind of be hit upon through Dr. Henry and Dr. Runyon's conversations, but then potentially in the Q&A. And number one is just kind of what I would describe as a bit of a, no matter what party you belong to, a bit of an attack on science and kind of the sense and sensibility. I think what unites all of us on this webinar is really thinking through why we chose a career in the health professions in some form. And certainly for me, thinking about becoming a doctor, I always felt like science, even when we didn't have clear answers, offered a clear conceptual framework or a clear construct by which to approach problems. And that appealed to me just from a personal and a professional level. And what's concerning, and it's very easy to see how there's kind of this politicization of COVID, masks, it's a hoax, all the kind of disturbing things that are out there. But I also think that this has not just started with COVID. It's actually started when we think about healthcare being kind of not considered a human right. So access to healthcare is heavily still debated about whether that's, something that you really have as a privilege. And then even before that, thinking about what I would say is decades of kind of, even though we've got incredible proof now about the effects of climate change and the interaction between the built environment, the actual natural environment, and our health, we still to this day, even amongst the physician community and other healthcare professionals, sometimes debate the merits of very serious trials that have shown kind of the proofs of changes in our climate of a couple of degrees and its effect on morbidity and mortality. So I think that's one theme I wanted to try to just, really stir the pot and say, somewhat in keeping with the theme, I think now more than ever, we need student activism to be, I see a lot of the benefits of student activism immediately when I do see that there are incredible movements in each town and city to help fight for human access, reproductive rights, et cetera. And then I think with COVID, the country has now seen what a lot of us have known for a long time. And I know that the other speakers will touch on some of this, but healthcare disparities, which has been well validated, well established, and strategies to overcome health disparities are still lacking in many areas. We are now just seeing all of that, to the 20th degree with COVID. So I hope that student activism within medical schools, within public health schools, and any actual undergraduate or graduate setting can force a conversation that unfortunately I do not think is happening. I still look around the ranks of leadership and faculty and, candidly, just putting up the pictures that you see that Ali went through where you have 3 women and it just doesn't exist in medicine, to be honest with you. So I would love to see student activism changing not just the shape of what we're talking about and who's talking about it, but also how we can lead kind of the general public in that dialogue. On a positive note, so that's one theme, kind of the attack on science and the role of student activism. And then I promise, I sometimes feel like I'm a little bit of a grim reaper in every conversation I've had these days because I'm just giving bad news. But I would say on a positive note, I've never seen more attention on concepts around public health than ever before. It would be highly unusual for me to ever believe that you could watch, Al Roker talking about like the R naught or infectivity rate of anything, but yet that's where we are. And I feel like if all we do is kind of allow for this to happen and then pass and be a distant memory without understanding how much we should take kind of this moment and actually build on this with activism that makes people in societies understand we've underinvested in public health. We've underfunded almost every single program in prevention that I can think of. And that we also have now exactly the kind of platform that other countries, South Korea, when they had MERS, much of Africa, when they've been affected by Ebola and SARS-CoV-1 and other diseases, we actually have that exact kind of scenario here in 2020. So I do believe that kind of out of this will hopefully be a stronger voice and bench for student activism, professional activism. And then third, I'm going to talk a little bit about kind of I think we're going to get maybe into a little bit of the looming battles around the Affordable Care Act and some of what I think could potentially happen depending on Supreme Court rulings. The elections, of course, are an important part of this. We've already seen some battles kind of being fought in the Supreme Court on contraception access, which maybe Dr. Runyon is going to touch on, but I would call that some in the losses column for reproductive rights. But I would also say that there were some victories in small ways, especially in red states around the country that chose to expand Medicaid despite having kind of an overwhelming, a Republican governor, a Republican legislature. And I do think that there is, especially now, a bit more of an acceptance, although it could easily get undone with an election. There is a bit more acceptance that states have that they need to do something, that without healthcare of any kind, pre-COVID even, people just are not going to be able to have like a livelihood, and employers are pressed to offer incredibly expensive benefits. And so you get a lot of pressure that I think is coming around, and you're seeing some of these red states that traditionally would have not ever expanded the Medicaid programs. Having said that, I do think that without going into, I'm all for, but based on my background, you can tell I'm a Democrat. I'm incredibly supportive of Vice President Biden winning. So I think that that's period, said and done. But I know that part of the concern that maybe some of you had is where do efforts like Medicare for All and some of the things that potentially candidates other than Vice President Biden were advocating for. And I think that's another opportunity for activism. I don't think any one candidate has one single solution to how we deal with the healthcare crisis that we have, especially given COVID. So I think the Affordable Care Act was an incredibly important milestone. I think there is much more that can be done. So kind of in closing, I would also ask that we use, November is right around the corner, 100 days from today, and that we do, in order to be an advocate for health, you need to be an advocate for making every vote count. And health, because of COVID, it always is a number one, or at least top 2 to 3 issue in voters' minds. I think that it will be a number one issue, maybe kind of encased in COVID, but I think that people will be understanding, because we've had millions lose their jobs. We've had, according to a Families USA report released last week, 5.4 million people that lost health coverage because of their loss of jobs. So, and that number is only going to grow. So I think that kind of there's an incredible permanency about how we can evolve as student advocates, professional advocates, and use everything from social media platforms, from engaging the public, kind of in meeting them where they are outside of our traditional healthcare environments, but then also creating that change inside of institutional healthcare. The Journal of Vascular Surgery, some of you might be aspiring or current vascular surgeons in the mix. The Journal of Vascular Surgery rightfully got incredible feedback when they had published what had been an abstract presentation at a conference last year around the inappropriateness, particularly of female physicians who either wear like swimsuits on social media or kind of images in social media of doctors. And it was incredible to see, and included a retracting statement from the editors, I think illustrating that even the House of Medicine, even when we like to think it's evolved, it still isn't. So I would just, I thank AMSA. I started my life in advocacy as part of AMSA, and am incredibly happy and humble to see that many years later, and I won't tell you how many, although you can Google and guess, many years later, AMSA is not only stronger than it was when I was there, but has now more than ever a more important role. So with that, Ali, I'll go ahead and stop and pass it on to my friend, Tracy.
Thank you so much, Dr. Patel. So much that we could just dive into right there, but we'll save some of the questions for afterwards. Just a quick reminder to everyone: if you have any questions for any of our speakers, please throw them into the chat below, and we'll also start off with the question and answer session with some questions prepared by AMSA's national leaders. Dr. Henry, if you want to share your screen, please go right ahead.
Okay, thank you. Can you guys see my screen? Okay, perfect. All right. Really happy to be with you guys. This afternoon, Sunday, very hot afternoon here in Georgia. Just like Kavita said, I got my health advocacy and policy roots are definitely grounded in AMSA, and this is how I ended up doing what I do today. And in fact, I am on faculty at Emory, and I do teach a couple policy courses. And so all of that was really grounded, everything that I learned in AMSA. So hopefully I'll be able to inspire you guys to continue on with what you guys are doing now once you're have graduated and practicing in your respective fields. So for my 10 minutes, I was actually asked to discuss some of the initiatives that we're doing to address disparities during COVID-19. And so briefly, we'll talk a little bit about the access. How did we figure out who were the high-risk patients and who were coming into the clinic and who were going to be telemedicine visits? What were some of the outreach strategies? And one of those was a student-led initiative, and I'll spend a little bit more time on that one. And then some of the challenges and lessons learned around meeting our patients where we are with COVID-19, especially those that are disproportionately affected by COVID-19. So before I begin, I want to tell you a little bit about our practice. Again, I'm at Emory, but I actually practice at GRADY Memorial Hospitals, where I do all of my clinical work. It's the largest public hospital in the state. It's the 5th largest public hospital in the United States. And the primary care center is actually located inside this hospital. And it's staffed by both Emory and Morehouse residents and faculty. Georgia is ranked 47th in the nation for percent of population uninsured. And our practice is mostly African-American, Latinx, mostly of low socioeconomic status. We see about 50,000 patients a year in the outpatient setting. And because of the great work we've had with social work and case managers, we've actually got our payer mix up a bit. So if you see on the side, when I first started there a few years ago, it was about 20% Medicaid, 20% Medicare, but now we're up to about 30% Medicaid and 27% Medicare, 17% commercial insurance. And that's super important because a lot of the patients typically take care of are resource poor or homeless. And over the last few years, we've had a huge effort. And a lot of this was driven by our medical students in getting our patients signed up for health insurance and other social services. And so just like Avita said, we hear this on the news all the time. So what are the problems? We all know a lot of our patients, at least the ones I take care of, are frontline workers in multi-generational homes. They can't telework, low health literacy. And the low health literacy one is so key and often under-discussed on the news. But a lot of my patients have said to me, I even saw one the other day in clinic, and they told me all these symptoms, the chest pain, this headache, worst headache of my life. And I go, why didn't you come to the hospital? And they said, well, I didn't know to come in. You guys said to stay home. And so a lot of them were listening to us and were adherent saying, I'm going to stay home, but they didn't know when to reenter the healthcare system. And unfortunately, a lot of those folks came back to our hospital on death's door. So these are the people coming in when they've had a heart attack or even after they had a heart attack and their EF's very low and poor health functioning, or they already have a stroke and with residual deficits that are too late now for us to intervene on. And so these are the kind of things that I'm seeing firsthand in my patient population. And of course, all of these things are rooted in systemic racism. And then just taking a look here at the chart, you see this cluster of lilac or purplish color. That's a disproportionate burden of COVID-19 on African Americans in the Atlanta metro area. And this, this you don't have to we won't spend a lot of time on, but this was the framework that my team came up with when we decided who comes into the clinic, who stays home, how are we going to meet the demands of our patient population. So we had to think about safety. So our staff had to feel safe. The environmental services who cleaned the rooms had to feel safe. Patients had to feel safe when they came in. We had to redesign our teams. How can we get the CMA to do this, or perhaps a medical specialty person to come to the clinic and see patients, while somebody like me could spend more time on the wards. Of course, we use virtual care. Which you'll hear a little bit, you've probably heard a lot about, we had to do a lot of virtual visits. For us, virtual visits meant just a phone call. We actually do not have the audio capabilities in our clinic. And many of our patients also do not have the smartphones for audio capability. So we had to think about all those things and how do we meet our patient population. And so these are sort of the grassroots things that you want to think about when you think about big picture policies and things that Dr. Patel may be working on. Is how does those big picture policies affect what we are doing, boots on the ground? And so in determining, who came in, who stayed home, we looked at age, we looked at folks with cancer and active treatment. Really in the height of the COVID pandemic, I basically was on service for 3 months straight, April, May, and June during the pandemic. And in the beginning, it was just people only with COVID coming in, only the people who had trouble breathing and just could not stay at home, and those patients with cancer. And so those were really the only types of patients were coming in. If they had a heart attack, heart failure, exacerbation, we kept wondering, where are these people? We have a ton of high utilizers of healthcare. These are patients who come in every other week, every month, and none of those patients were coming in during the pandemic. And so we were wondering, where are they? Are they dying at home? And then those are the questions that helped led to the couple outreach strategies that I'll highlight in the later slides. And then there was those also people that had to come in for telemedicine visits because they were lost to follow-up. So if you weren't seen in our clinic within 2 years, you were considered a new patient, and CMS was not paying for some of those visits. So they had to come into the visit. We couldn't see them virtually. And then obviously those are new patients and folks that were recently uninsured because they lost their job because of the pandemic and a lot of the closures. And then there were also patients with disabilities, such as the deaf population, who primarily use sign language. So I won't go into the weeds on this, but basically we had a COVID clinic, a separate clinic for patients. We had a task force to help with sort of this moral distress because our patients were worried, our staff were worried, and you really have to think about all of those things when you're figuring out how do you address disparities in your patient population, because you have to have a supply, you have to have a workforce, but we also had to kind of manage the demand as well. And our primary care clinic never actually closed, and I'll tell you why. One of the reasons is a lot of our patients did not have a cell phone, right? Or they didn't have internet. We couldn't patient portal them and say, hey, clinic's closing. And so no matter what, we always had to remain open because a lot of patients depended on just walking up to GRADY to get their health care. A lot of them are homeless. And so we couldn't call them to say, you cannot come back to clinic. And so a lot of those patients continued to come into the clinic. And so one of our outreach strategies I'll spend maybe a minute on is mobile integrated health. And basically this is just these old-fashioned house calls. And so family medicine, I believe that's still part of their training, but internal medicine, it was part of our training a long, long time ago. And I would even say, perhaps this is a call to action, and that we bring this back in our medical education training. We do offer these at our training programs at Emory, but it's not required. So it's not required by LCME, it's not required by ACGME for the residency program, but perhaps it should be, right? We need to start bridging the gaps and meeting patients where they are. And so some of the other great things about the mobile integrated health that I liked is a lot of our patients have a lack of transportation, so they didn't have to take public transit. It was safer. They didn't have to come into the clinics. It was less wait time than an important appointment. It addressed a lot of the health literacy issues. We see their pill bottles. We know what they were taking. Some of our patients, our average patient, their literacy level is 5th grade, either 7th grade literacy. And so going into the home, seeing what they're taking, you could write on those. You could, draw some things on there and help the patient remember this is what to take and when to take it. And so it was a lot of cost savings. The patients enrolled in this program, 30 days from being enrolled, just by coming out and meeting them where they are, we had a 50% reduction in 911 calls. And so I say this is something that perhaps we should invest in. We actually are not being reimbursed for these visits. So that's another big regulatory thing, another big action item for advocacy to think about. GRADY is a large academic center, so we're absorbing the cost of this mobile integrated health unit by saving on the patients that are not being readmitted to the hospital. But this is definitely something that we should invest in, if we think about healthcare going forward in the future. So the other big thing I wanted to spend a little bit more time on is the student-led initiative. And this was really great. So a lot of the med students, these were mostly our second, third, and fourth year medical students who were supposed to start wards in March. So they were literally on wards for 1 week, and then we pulled everyone out of the clinics, everyone out of wards. And so they were sitting, twiddling their thumbs and trying to figure out what can we do to help. And remember, I kept saying, we have a ton of high utilizers, a ton of people come back and forth in and out of the healthcare system. So they sort of answered that call. They said, okay, so what can we do to help these patients? The ones who had actual contact information, they used our JVON, which is an artificial intelligence system that looked at age and number of readmissions and comorbidities. And so they stratified all of our patients as high risk or not. So we had over 13,000 patients that were stratified as high risk. The med students did all of this. They worked with the AI system and everything. And then once we did that, they started calling, starting with the highest to the lowest risk. And they called over 660 patients in that first couple months of the pandemic, which is amazing. So and I'll go over sort of the results that they had here. They were able to identify a ton of major gaps in services and needs and what they were needing during the pandemic. And so the way they did it, they had this sort of pre-call side where they did a lot of chart review, figuring out what are their issues, what are the things they had previously been needing, medications, are there someone whose sugars run really high? Is this someone who's always coming in with volume overload, so that they could tailor the calls whenever they were getting in contact with the patient. And then you look over in part 2, the patient encounter. And so, this was an opportunity to figure out, what sort of med supplies they need, what social needs they need. Did they need behavioral health? Did they need a ride to the clinic? Should we have them come in? And then the next was the post call. So they would do a lot of documentation in the chart. They would make sure they get all of the referrals. Those that were really ill, they would contact a faculty like myself or another faculty member, or either the advice nurse during the time, and then they would get them either into the clinic, to the ED if they needed, or a follow-up appointment. And so you might be wondering, these are students who are just starting their clinical rotations and may not have had a whole lot of opportunity to interact with patients. And it's really hard for us as attendings who've been dealing with patients for 10 years to really focus a visit over the phone. And so what we had was this protocol in REDCap. They took a lot of notes, and these notes helped them when they were in their visit. So it'll keep them on track and say, oh yes, I need to ask them about this medication. I need to ask them about this, their hypertension or their diabetes. And it helped them stay focused and streamline the visit, because it's really hard sometimes, because you're probably the first provider or health professional that they've talked to in a few months. And so they want to tell you everything, but this helped them streamline the appointments. And then we also use something called Skip Logic. Again, these are all new people, second, third year medical students who are just kind of getting their feet wet. So they may not, they probably wasn't sure exactly what should I do next. So for instance, if during the coronavirus screen, if someone had a fever and trouble breathing, then there was something that will pop up for them. They click the box and they'll say, since I'm not a doctor, it would be better for me if I get someone that can help you. And then they will get someone to help the patient. And then the other piece was, if there was fever, no symptoms, then they can feel comfortably saying, it is okay for you to stay home as long as you can physically distance. So this Skip Logic was able to help our students customize their advice in real time. And then this is our sort of preliminary findings. And this is actually data from a month ago, but we're constantly sort of updating it. But at least of those first set of calls, a third of our patients needed medication. So that probably tells you why so many of our patients came in at death's door. They were out of their meds, out of their heart failure meds, out of their hypertension medications. A third needed medications. At least a fourth said, I really wish I could get to a PCP. So we made those appointments. Half of them needed something that was socially needs related. They needed food. So they had food insecurity. We could get them some food. They needed medication. So we got our pharmacists to drop off medications to their homes. They needed help with rent and housing and utility. And so you probably saw on the news all of these different resources for patients, but a lot of my patients just wasn't clear how to access it. And a lot of the way to access it is online. If you don't have internet, how are you going to access these resources online? And so this was really an awesome opportunity by our students to really figure out, meet patients where they are, and they were to help patients fill out a lot of these forms and get the care that they needed. And this was just an example of some of the referrals made. And then just some lessons learned. I won't go through all of these, but a lot of our patients that we talked to have recently lost their jobs. So I was really happy in pointing out our payer mix, right? This payer mix is probably likely to change. So many of my patients have lost their jobs. We're probably going back in the other direction that we were when I first started there 4 years ago, where a lot of our patients are going to need some sort of Medicaid or some other, less of them going to have that commercial insurance. And so another thing that we need is bi-directional efforts. And so we hear a whole lot about social determinants of health, but physicians, healthcare professionals cannot do all of this alone. Like literally, we need to work directly with communities. We need to know what they want so that it's not just us referring out to resources. The community folks should be able to refer back to us and get people connected into healthcare. And then we need healthcare outside of the four walls, outside of our clinic walls. We need to go to where patients are. And then these proactive calls are amazing. But now the students are back on the rotations. Who are going to do these calls, right? Do we have the workforce? We need the ability and regulatory changes in payment in primary care so that we can continue outreach efforts like this. And basically, these are some of the challenges, like I said, the regulatory environment, reimbursement. And what I mean by that is in primary care, we're still a lot fee for service. And so if we're paid for everything we do, even though a lot of what we do is cognitive, that's a deficit for us, especially during COVID-19. And just sort of to make this real, a lot of independent private practices had to close down during COVID. And I am in a large academic center, so we're able to absorb some of those costs. But even those folks in large specialty practices, right? You could be a surgical practice or something like that. They've had to furlough a lot of their staff because they had to cancel a lot of the cases. So we really have to think forward going into this next administration. What should healthcare look like? How do we reimagine it? How do we need to reevaluate what works, what doesn't work, and then redeploy what we're doing. So we need a flexible healthcare system. We need adaptable. We need, a way to pay for all of our services, including cognitive services. And that's basically what I said there. And pretty much that is it. I hope you guys are really thinking about ways you can advocate and be involved in this next election. The way we change healthcare is really key right now. So a lot of my patients, like I said, we were so happy we were getting people insured, and now we're kind of going back in the other direction. I've seen a lot of disparate actions and things going on in the community, and a lot of it begins with healthcare. Thank you.
Thank you so much, Dr. Henry. Dr. Runyon, we're going to turn it over to you to talk about the intersection of reproductive health and justice with COVID-19.
Thank you. So these have been some really great points made by Tracy and Kavita, and I'm just trying to follow that up with some comments on reproductive health. So like Ali said, I'm a family planning provider. I also practice gynecology and I do obstetrics on a call basis. And so I'm a little bit north of New York City. And so we had to kind of, I'm at an independent clinic. And so like Dr. Henry mentioned, a lot of these clinics have had trouble during COVID in terms of non-essential services. But that kind of links to what I wanted to start out by talking about, which is our clinic had to stay open because abortion care is an essential service. It is, there was a lot of talk during when surgeons started talking about canceling elective procedures. And of course, the anti-abortion movement jumped right on that and wanted to, in several states, including Ohio and Texas, wanted to limit access to reproductive health, including abortion, by calling abortion an elective procedure. And of course, the word elective means something different in medicine and in surgery. It means a procedure that can be scheduled in advance. It's not an urgent procedure or an emergent procedure. However, abortion care, of course, has a timeline. We have a legal limit in most states, and in some states that limit is even earlier than in New York. And so this was definitely a way that COVID-19 did impact reproductive health. And so, of course, in New York, it's more, thankfully, we have a more liberal state and more liberal regulations. We were able to stay open. We did have to navigate challenges around, taking precautions, having patients, of course, wear masks, take temperatures, and just be very careful in terms of protecting our staff. But in general, throughout the country, the pandemic, as well as, of course, the racial justice movement that has erupted recently has shined light on a lot of existing disparities in health. We know in reproductive health and in obstetrics that Black women and women of color definitely have higher maternal mortality, also sometimes less access to abortion care. And this is not new, unfortunately. This is because of systemic racism and systemic racism within healthcare. However, the pandemic has kind of put that into even more abrupt focus. So that's something that we definitely have to work on as a system, recognizing it, naming it, and then being able to do something about it. And not only that, we've as Dr. Patel mentioned earlier, we've had some wins in terms of reproductive health and reproductive justice, but we've also had some setbacks. And the wins include the June Medical Services decision in the Supreme Court, which thankfully upheld the right for Louisiana abortion clinics to stay open. That case was around admitting privileges, and it was actually a very similar case as to Whole Women's Health in Texas, which was about 4 or 5 years ago, which is basically saying that abortion clinics had to have admitting privileges within a certain radius of their clinic. And as most of us know, and we know in healthcare that abortion is a very safe procedure. Most doctors don't need to transfer patients. Most doctors don't transfer patients after an abortion. However, this is what the law was trying to set up. And basically they did that in order to shut clinics down. And so thankfully that was not the case this time in Louisiana. However, something that we need to kind of think about in terms of reproductive health and justice is that in a lot of cases, while this is a win on a federal level, a lot of the time Roe v. Wade being, while we still have to fight for it, and it's very important that federally abortion is protected, for more often than not in states that are, not expanding Medicare and Medicaid, not that have gestational age restrictions, that have TRAP laws, which are the laws that are restricting clinics from opening, restricting clinics that don't have admitting privileges, that Roe is often more of a theory than in practice for a lot of women. And so this is something that, of course, we applaud Roe. We want it to, be supported and withheld and everything. However, we have to look at more of a state level and state level access for abortion care, because a lot of times, even though the federal protections are in place at the state level, there's a lot of restrictions and loopholes that patients have to go through, and especially those who are disproportionately affected socioeconomically. If anyone has the money, the time, the childcare, they can pretty much access an abortion. However, that's not the case for a lot of our patients. And so that's something that we really have to understand and think about. Also, the Hyde Amendment, for those of you who may know or may not know. So this amendment prohibits and has prohibited for many, many years federal funding, including Medicaid, for abortion care, for abortion procedures. And so the Hyde Amendment has been in place. It comes up every time a new bill is passed. Usually the Republican side wants to put the Hyde Amendment into any sort of funding package. They attempted, I'm not sure if they did or not, but it probably did pass in the first COVID relief bill. And so recently, however, Representative Ayanna Pressley, along with Representative Jan Schakowsky, who will actually be speaking at one of our events in August on reproductive health, those representatives and a few others actually proposed an amendment to repeal Hyde recently. And this is a step in the right direction. It's been a long over, years long battle to try to repeal Hyde. And it's hard because a lot of times the argument for abortion access is often kind of hinged around, but my taxes isn't paying for it, or but federal funding is not paying for it. But unfortunately, this disproportionately affects, and we know this because this is what Hyde said was his. This was his whole point of passing the Hyde Amendment. Is he said, I can't deny abortion care to everyone, but I will deny it, or I want to deny it to people that don't have the resources, and that's literally what he planned to do, and that's what he did. And the Hyde Amendment, unfortunately, still does that. So women who, again, disproportionately women of color, Black women, women of low socioeconomic status are disproportionately affected by this. And of course, denying a woman an abortion often puts her and her family keeps them or puts them in a lower socioeconomic class. This was shown by the Turnaway study that was done out of the University of California, San Francisco. And so it's been studied and it's been demonstrated, but yet we still are under the Hyde Amendment. And so that is a place for action in terms of writing representatives, making phone calls, et cetera. It's really important to overturn. And then I think as Dr. Patel also mentioned, with another recent Supreme Court decision around birth control access, it was not a good decision in terms of the Supreme Court basically said that employers can basically decide for their employees whether their insurance will cover birth control, which is absurd when you think about it. Your employer should not be deciding whether you get birth control access, and because of our insurance, most people's insurance being linked to their jobs, this is kind of the way the system is set up. But that's definitely something that can be advocated against, or make sure that that this doesn't continue. We can on a state level, and then hopefully on a larger level, on a federal level. So that's another issue that is kind of a call to action or advocacy. And then I'll just kind of end by just commenting on the fact that just this past weekend in the New York Times, there was a whole spread by a bunch of different reproductive justice groups, including Sister Song, including Ancient Song, which is a group of women of color who are doulas, basically put out a whole, several pages in the New York Times about maternal death rates. The cover said something about how long will Black, Brown, and Indigenous women continue to die giving birth. It was pretty provocative. And then they set out a list of things that we should be doing, legislation, as well as policy-based to prevent more maternal death, especially in those communities. And so if you haven't seen that, I would definitely Google it. It's in the New York Times. And I think that we're seeing, while unfortunately COVID has been obviously a huge setback in a lot of ways. And of course the racial justice movement is definitely necessary and needed. It's unfortunate that, I was watching John Lewis's body cross the bridge that I'm hoping they will name for him, because it doesn't need to be called the Pettus Bridge anymore. But he fought so hard and he made so many sacrifices, and unfortunately we're still kind of dealing with a lot of the same things that he, fought so hard to make sure weren't going to keep happening, in terms of, racial justice and access to health care. And so it's really important that we take up that call to action. We, for his legacy, as well as many, many others who have done this for so long, it's really important for us to be, that next generation that keeps the fight going, and hopefully we can turn the tide a little bit and make sure more of our patients have the access to the care that they need.
Thank you so much, Dr. Runyon. And thank you, Dr. Henry and Dr. Patel as well. We'll move in here to our question and answer session. I think it's unfortunate that we have such limited time because there's so much we could be talking about here with the wide range of the issues. We'll kick it off with the question and answers session with the question that was submitted from before. And if anyone else is having some questions that they wish to propose, just drop it in the chat and we'll get to that. Let's start off here with a question for you, Dr. Patel. In light of threats to Medicaid funding and the SCOTUS, like ACA challenge, what do you see as the biggest threat to access to care? And what are your thoughts on the state of the U.S. healthcare system?
I think the biggest threat is if we do not have kind of a shift in the kind of politics of Congress and the White House from an election outcome, because I think it's been pretty clear that we've already got, we had attempts at the beginning of the Trump administration in 2017 to kind of repeal and replace the ACA. And the difference now, there was really no replacement plan. I think the difference now is that you've got a kind of a near depression economy. And if you look at the cost of healthcare just sheerly by the numbers, you're going to have like a little bit more of, unfortunately, depending on the outcomes of the election, you could have a little bit more appetite to say, there was aspects of the Affordable Care Act that made healthcare more expensive, which is not true, but would become a little bit of a sounding call to say, let's roll back some of this access. We've already seen that with administrative actions to allow what I call junk plans, which are skinny benefits and patients who are incredibly susceptible to not realizing they're signing on to getting health insurance that's cheaper, yes, but won't cover things like mental health or cancer coverage, for example. So I think that's the biggest threat.
Thank you. Dr. Henry, Dr. Runyon, if you wish to jump in as well, otherwise we can move on to another question here. Okay. Well, next question we have is actually coming from our REACH committee. I'm going to turn this over to Ebony.
Hi, Dr. Henry. This question is for you. We wanted to know what steps can be taken to draw attention to and dismantle systemic racism in the medical setting as well as the curriculum. How can we prevent future physicians from sustaining the bias that discredits people of color and perpetrates their mistrust of physicians?
Oh, Ebony, yeah, that's a really, really great question. So again, I'll turn it back to what we're doing at our institution. So I can actually say our students, after the whole thing with George Floyd, that became sort of the catalyst we hope for change in America. And so not long after that, I helped some students draft a statement that race is a public health crisis. And then from there, it spawned, we had student groups who actually started a whole diversity, equity, inclusion curriculum. And that curriculum included several things. We also have already met with Emory School of Medicine, and they just kind of set through it. And I think a lot of these things will actually go through. And so just kind of walking you through some of the things that we asked for in the curriculum. Number one is, you hear a whole lot about implicit bias training, but how much is enough? Some of the studies show that even if after 6 months after even doing implicit bias training, whatever gains that you have are lost. If what actually sustains sort of what we learn about implicit bias training comes from our relationships with others. And so in doing that, our curriculum shouldn't just be a one-time social medicine elective or a one-time I send my med students out into the community throughout their entire 4 years. It should be interwoven throughout the entire medical curriculum. And so some of the things that we're asking for is not only implicit bias training for the students, but also for the faculty and the staff. We're also calling for removing a lot of the biases that we have in our test questions for the students. And so in having a panel that can actually review some of those things. I previously worked on the board for the National Board of Medical Examiners, and that's some of the things that you may see on their website that they're working for as well, because we still see in the test questions, if you're Black, that you likely have schizophrenia. And then, if you're white, you might be bipolar, or Black and it's sickle cell disease, but it could be anyone of Mediterranean descent, right? And so there's all of these sort of, or immigrants are less vaccinated and all these different examples. And so we want to remove all of those biases in the test questions. Other things we started was an anti-racism committee as well, and microaggressions and upstander training, or what we call bystander training. And so what we've seen is a lot of students have said, I've seen this on the wards, I've seen this in the clinic, but I don't know how to stand up. I don't know how to address that when I see it. And so this empowers students. And so we've already started having trainings for our faculty, staff, and students. And afterwards, you feel a little bit more empowered to speak up when you see it. Another thing that we're also doing to help with the curriculum, we're doing a bunch of stuff, is that I also do something called diversity dialogues. And so we have been going through each department and making sure we have a place so that people can kind of talk about what does this mean to really be an ally, and how to be an active ally, and so that we can address things in different areas. And then there's a ton of other things I won't, belabor, but we're doing a lot of things, and there's so many ways to attack this in medical education. But I really think a lot of it starts within, because there's a lot of biases in medicine. And I'll give you one final example. There are a lot of clinical algorithms that we use. And so another thing that we've been working on is how can we get rid of some of these clinical algorithms that are based in bias. For instance, you guys all heard about the GFR, right? And how it's based on that they assume African Americans have higher body mass, and so so the calculation is different. And so our GFR at any time is higher than a white person's GFR, which is, that calculation is not true. It's nothing. Race is a social construct. And so what happens is you see most of the people who are disproportionately affected by kidney disease and end-stage renal disease are people of color, but there's a delay in getting them to dialysis, getting to nephrology, because the primary care doctor is looking at the GFR and the creatinine. But if that's based erroneously on some weird calculation, then that's a bias itself. And so there are a ton of those clinical. There's one in with the VBAC, a vaginal birth after cesarean section. There's some in how we decide about getting sort of heart treatment. So they're everywhere. And so there are so many things that we can do. I think we just have to pick one, and start tackling it. And then eventually we'll get all of these things done in medicine. Thank you.
Alrighty, and our next question is actually for Dr. Runyon. How can students help ensure that all their future patients can access the reproductive health services they need, including abortion care?
Yeah, so this can be complicated, and it can depend on what state you live in. In some states you have to kind of push harder than others, and in some states they're going to be it's going to be more difficult. But I think starting with kind of a basis. So, at AMSA, we have the Reproductive Health Project, where we have, events we have 2 events currently going on, 2 leadership programs, also a scholars program that kind of tackles these issues. Some of you may be in them. We have a reproductive justice leadership program going on right now, where our next speaker will be Loretta Ross, which we are very excited to have her, because she is one of the founders of the term reproductive justice and the movement that surrounds it. And she's an incredible speaker, an incredible person. We also have a career pathways in family planning leadership program. And I mentioned the Turnaway study earlier, which is an incredible years-long, multiple people involved in terms of research on what it means to be denied abortion care. So kind of having the access to those resources, knowing where to go for them. Other organizations that are really good to get involved with are Medical Students for Choice. They have a website, they have an Instagram page. I'm pretty sure there's multiple chapters at different medical schools, just like with AMSA. There are fewer of them, but they are at multiple different schools across the country. There's another organization that is actually a group of lawyers and law students, but it's called If, When, How. They're a really great group to follow. If, When, How comes from if you want to, women should have the choice if they want to get pregnant, when they want to get pregnant, and to parent their children, how they choose to parent their children. And that's women and that's non-binary women, that's trans women, that's cis women. And so it's a wonderful organization. I follow them on social media because they always have really up-to-date posts on what legislation is going on. I found out about the amendment to hide through their social media page. The Center for Reproductive Rights does a lot of great work, and they've done the work in terms of like putting out the lawsuits. They litigated the Supreme Court case for Louisiana. And so just following these organizations and having that knowledge, that baseline knowledge, and then getting involved at your local level. So whatever institution you're at, of course, you don't necessarily even need to be interested in OBGYN or even family medicine, but those are kind of the two specialties that track most of family planning providers. But if you're going to see women, it's 50% of the population. And if you're going to be referring women to care, it's good to know where they can go. And it's good to get involved with the people that are doing the family planning work at your institution. And then if you're in a more restricted state, or if your institution doesn't really have family planning, it's always good to seek out Planned Parenthood locally, in terms of being able to kind of shadow and like see what they do and see what advocacy work they're involved in. Also joining or being involved in your local ACLU chapter is actually really important, because they do a lot of the litigation against these bills that get passed. And then finally, I was going to say another organization. Oh, the Abortion Care Network. So ACN, it's kind of a loose umbrella of independent abortion clinics throughout the country. So along with the National Abortion Federation, they kind of are the parent, not really a parent organization, that's not the right word, but they're kind of the umbrella organization of the independent clinics. And so for instance, my clinic is an independent clinic, and we're part of that network. So if if your medical school doesn't necessarily have like particularly family planning services or people that are in that work, you can go through the Abortion Care Network, find the closest clinic to you, and then email the office manager and say, hey, I'm a medical student. I'm really interested in this work. I would like to see how your clinic functions, any advocacy work you're involved in. And that's really a great place to get started. I actually, even though I'm working now at an independent clinic, I actually did get started in this work through Planned Parenthood. I was a medical assistant at a Planned Parenthood in Florida, where even before medical school. And it was always in the back of my mind. I was trying to be very open about my specialty choices, but kind of always came back to reproductive health care. And so again, and also following our AMSA reproductive health project is a great way to get involved.
Thank you so much, Dr. Runyon. Next question is coming here from the Just Medicine campaign. Nadia Rohini.
Yes, hi, sorry, I was muted. This question is to Dr. Patel. We wanted to know, how can we advocate to the pharmaceutical industry about reducing pricing and engaging in drug pricing policy change discussions, including engaging other medical students to raise their voices, especially about the COVID-19 drug pricing?
Yeah, that's a great question, and a tricky one, because I actually think pharmaceutical manufacturers got a pretty big pass because of COVID, even though not everyone is developing something for COVID. I'll candidly say that I think it's important to just keep, it'll be hard for one medical student to kind of have an individual approach, but I think that, again, like for me, a top line effort is to just get people to vote, because I do think that this year will matter in terms of what shape a Congress will take on pharmaceutical pricing. And then the second is really, I think that for too long, students are working in environments where we've just kind of passively accepted that it's okay to pay and fill in the blank amount for pharmaceutical prices, but when it comes to healthcare costs, it's really like the doctor's fault. So I do feel like there's probably a very good, I would say, number one, if you are kind of wanting to act as an individual, really capturing the stories of your patients or what you're seeing, because I actually think those things break through. I think that if you are able to work in part of a group, part of a national movement, it really is to kind of pair with some of what I think are really popular, more patient advocacy oriented groups, everything from Families USA, all the way to some of the kind of cost alliances that have been trying to help reduce the cost of care. But I also feel like there needs to be some policy. What would be good for those of you that are policy minded, it's not enough to just say reduce prices, because it's not as if we have a system that really has a pharmaceutical company, quote, setting the price and that's what you pay. there are so many intermediaries and people and companies that get in between that. So I think it's also holding people responsible for why it is that somebody who has a certain type of benefit will only pay $5 for a drug and somebody else might pay 500. And I do think number one, you need to educate people. And then I think that we can't just pin this solely on kind of the evil drug company, because that tactic isn't working clearly. And I also don't think it's reflective of the truth. I think there's this pharmaceutical benefit managers, private health insurance companies. I mean, there's just a whole cast of characters that result in that end point of a patient paying or having to make a decision about paying their bills or paying for their drugs.
Thank you.
Thank you so much, Dr. Patel. We have a question here from the Environmental Health Committee. Heidi, are you on?
Yes, I am. Thank you. This question is directed towards Drs. Henry and Patel. How can we make environmental justice an important topic to discuss in terms of racial inequities? And then secondly, what's our role as medical students in ensuring environmental justice and health equity?
I'll just say briefly, really, I think the environment is something that is often slept on. Part of my speech. We were just talking about this earlier, how the climate change, and everyone wants to forget that it's not happening, but this is everyone's problem. And so how we can get more people involved is to have more conscious organizations. We're working on getting a group of medical students together that want to address something like this. And I think it really it starts grassroots, it starts in the communities, but it also starts, we need our medical organizations to get involved as well. And I'm part of the American College of Physicians, and we actually tackled this a year or so ago with a position paper on the importance of climate change and environmental justice, because it does affect our community. So I really think getting more medical students involved and knowing the problem up front and early on will perpetuate, because I feel like our students are the conscience of us all. And as we get further out in our training and in our practice, we kind of forget about all the basic things that we really need to be advocating for. So I say, let's get more students involved. I'm not sure if AMSA still has a committee directed towards this right now, but if you do, definitely reaching out to schools, because our particular school doesn't have one of these, but it's something that we're working on. And I think that would be the way going forward.
Thank you.
Dr. Patel, anything else to add there?
No, I don't know. For the sake of time, I would say that's perfect. Nothing.
All right. Wonderful. I have a question here from Zareed. Hey, Zareed.
Yeah, thanks, Ellie. So, as we know, women who come from marginalized or low-income neighborhoods, they obviously are at a huge risk for COVID because of the lack of information resources already. So how can we ensure that these individuals have access to the essential reproductive health care services that they need during this pandemic?
Sorry, I was muted. That's a great question. And so one of the things that I actually didn't mention before was, so medication abortion is one of those areas where this is actually moving a little bit, and hopefully it will move some more. So for those of you who aren't aware, so medication abortion consists of mifepristone and misoprostol. And so these are both very, very safe medications. They can be taken at home, and well, they can't be taken at home except for the issue with mifepristone, which is an antiprogestin. So otherwise it's a completely safe medication. It unfortunately is registered on a list for the FDA called REMS. And so this is a list where other medications are registered, such as chemotherapy drugs. And it's so that they can monitor drug toxicity. So mifepristone is not a toxic drug. However, it ended up on this list because of obviously political reasons and trying to limit medication abortion. So because of COVID, and because more medication, not only because of COVID, but also medication abortion is becoming more popular, we can, now more than before, we can detect pregnancy earlier. And we also have medications that we know are effective in the first trimester. And so medication abortion is becoming more popular. Women can take the first, well, in some states, because of regulations, they have to take the first pill in front of their physician, and then, which is silly, they shouldn't have to do that, but then they can take the other pills at home and have a miscarriage at home. And so because of COVID and because of the need for not having in-person visits, the FDA temporarily removed that restriction that made a woman have to come in and take it in person. And so now the pills can actually, and so that's at a federal level. In some states, that restriction still is in place at the state level, that it has to be an in-person, the patient takes the mifepristone in person. However, in other states, the pills can be mailed. So this is one way that access can be increased, especially for abortion care. And then in terms of contraception, that kind of goes back to the employer insurance issues. It also, has to do with whether insurance and Medicaid is expanded in certain states in terms of access. So a lot of these issues do go back to political advocacy. And so what the family planning and mostly the family planning community is trying to do right now is to make sure that once the pandemic is not, I don't know if we can say over, but once we're able to have more loose restrictions in terms of patients coming in person, it's still important to have a very safe medication be able to be sent by mail, or a patient can come pick it up. But in order to increase access to that medication and to abortion care. So a lot of these things are state level, federal level. This is why I was mentioning before, getting involved with the legal organizations are actually really important, because as a future physician and as a clinician, while it doesn't seem like it in terms of COVID, in terms of our voices being respected, they are in this case, and we have a lot to say in terms of what our patients are facing, because we see it every day. And then we can be that voice. We don't necessarily have the legal know-how, but we can be the clinical expert in the room, in cooperation and advocating alongside those legal organizations. And so I think that's the way to start. And you don't have to start at the highest, definitely lobbying your representatives is important, but in terms of a federal level, but also at a local level is really important. I think we kind of don't often underestimate the importance of local level advocacy, because if for instance, I'll just use my clinic as an example. I'm in New York. Technically we should be able to mail these pills, but at my clinic, there's kind of some pushback on the staff side. And they're like, well, the patient should come in for a visit. And it's just kind of like old habits die hard. And so it's up to us to kind of to help with, educating, staff, educating our, the circle that we're in, colleagues, that kind of thing. Because it is true that old habits die hard. And if we've been used to giving out mifepristone with a doctor present, then that becomes the norm. And even though the medication itself is not a toxic medication. So those are some ways to get involved.
Thank you, Dr. Runyon. I think we have time for just one or two more questions that especially came in. Here's a question, I think maybe towards you, Dr. Henry, but anyone feel free to jump in. Any recommendation for resources on bystander training?
Yeah, I saw that. I can send whoever, if you send me an email, tlhenry at emory.edu, and I can send you some things. I give talks on it, and so a lot of my colleagues, but I can definitely send you some resources on that. Perfect.
And then another question here, and maybe we'll make this our last question for going into AMSA updates here. Perhaps, Dr. Patel, you'd like to talk about this a little bit with regard to the healthcare workforce, especially in the age of the pandemic, discussing having the workforce properly equipped, especially when it comes to numbers, and that includes international medical graduates and physicians coming from abroad. Do you have any comments on some of the restrictions that are being put in place at this time, and what some of those threats are?
Yeah, I saw that question. I'll be honest, I didn't know about the ECFMG kind of dual tracking. It looks like kind of what they're doing for certain medical graduates versus American
Sure.
ones. So that, but I'll say more broad. So to be honest, I'd love to learn more about that. But to be more blunt, I think what you're watching is just this incredible, like, ethnic and racial kind of, in my opinion, nothing short of just blatant racism that's being exhibited through policies. I'm not shocked that it's happening in the administration. This is the same administration that is continuing to keep detention centers open with children, even despite a pandemic, particularly in the hardest hit parts of Texas. So I think that this is just one more flavor. I think you saw that the Trump administration made kind of a reversal on certain visa status because of pushback around healthcare workers. But I think that that's all kind of like, oh, sorry, we got a lot of feedback from like certain states that were more Republican and they don't like it. So that's unfortunate. So I would say whether it's this ECFMG issue or kind of visa status issues, candidly, it's just another, you know, I'm going to sound like a broken record. I'm pretty sure everybody on this Zoom is going to vote. I hope they are. But I also hope that each one of you use the fact that you can, by your status as a healthcare professional and person in training, get everyone around you to vote, including patients. So that to me is another reason to emphasize that. I would also say that even when I was AMSA president, we went through the whole kind of change with the USMLE and foreign medical graduates and kind of in-person testing requirements. And I think that there is just always going to be this kind of unfortunate scrutiny for graduates, for people who did not graduate from United States allopathic or osteopathic medical schools. And that doesn't matter where you were born, it just has to do with this kind of sense of, I'll call it American exceptionalism. I think there's been data to support that that's no longer merited, but I think that our testing strategies have not caught up. And so not only has our testing strategy not caught up, but our visa strategies have not caught up, our hiring strategies have not caught up. So what I would suggest is that as Tracy kind of pointed out, I spend more time at the policy level. I would say at a policy level, we need to identify strategies to increase an equitable healthcare workforce. You can pile into what the word equitable means in many different directions, but I would strongly urge AMSA to be part of leading what that looks like. And that includes the comment I made up top that I will leave this very like lovely environment where I see so many women and people of color, and I will return to like the ranks of healthcare where it's pretty much a bunch of old white guys. So in order to really create the environment that we want to practice in, I think we're going to have to work on many of those levels to dismantle it. The ECFMG, the visa status, testing disparities that exclude people where English is not their first language. To me, that's just part of it. So, you know, what we want is quality healthcare, and what we want are people, I'll tell you the truth, I want more doctors that look like the patients I serve. Like, I think it's fundamentally flawed that I practice in a Latinx clinic and that it's just by luck I speak Spanish and that I can pass for Mexican, but there is nobody in our faculty, there is nobody in our practice that's actually, you know, of Latinx origin. And that's not an accident. It's not because Latinx students aren't interested in becoming doctors. So I'll end. Ali was saying that if you want to get to some of that, also medical students have to take a much more active role in all policies, education, housing, nutrition. Because of all the Ali's, a lot of us are involved with trying to help, you know, change the White House this November. I think it could be incredibly compelling to try to take a role in working with educators on how to think about recognizing children with health needs. COVID has again illustrated to me how little we have of that. So I think all those things can help this issue of what a healthcare workforce looks like. And maybe it's a healthcare workforce where we're not working in hospitals and clinics and we're working in the community setting, but in very unusual places.
Thank you so much, Dr. Patel. In the last few minutes over here, you know, especially in light of today and this week marking, you know, the anniversary of landmark legislations like Medicare, Medicaid, and the American Disabilities Act, and especially as we're thinking about the late Congressman John Lewis, you know, AMSA is a place for future physicians to carry on its legacy, and that includes sometimes making good trouble and the necessary trouble. So we'll take like these last few minutes just to, before we wrap up here, to provide some of these updates of some of the programming coming here and some actions that people can take on all these wide range of issues and to get more involved there. The first up here, I'm going to turn this over to Thomas, who's with the Wellness and Student Life Committee.
Hello. Thank you. This has been like a very powerful talk. And this has been important to show about like what advocacy can do. And for me, I think advocacy also is very important to advocate for our own well-being. As medical students and just medicine overall, it can be a very rewarding but very demanding field. The statistics aren't great for us medical students. Half of us will experience burnout. So it's very important for us to like really take time and care for each other. And AMSA does a really wonderful job in really trying to help support medical students. There's a lot of policies that we have that are in relation to medical student wellness and resources. AMSA also works on partnerships with other organizations to help improve student wellness. Our EAF, Maddie, has been working on a collaboration with the Physician Support Line, which is this amazing call support group staffed by psychiatrists. So doctors can call them for free to get some like peer support, and even medical students can call. So that's something that we're working to help advertise more for the medical students. And then there are other like collaborations being done that our committee is trying to help just highlight and promote more. And secondly, like our committee is also working to try to help with improving like and increasing original AMSA content and promotion on wellness and resources. We'll be working on a series of AMSA wellness and student life blog posts. So please keep a lookout for that. And thank you.
Thank you so much, Thomas. Next, we have a quick update here on from the Environmental Health Committee. Going to turn this over to you, Heidi.
Ollie, do you have thank you for putting up the little infographic there. Hi all. First off, I want to say thank you so much to the panelists for your time and for your talks and for your thoughtful answers. We're so grateful for your experience and for your involvement. So thank you very much. I wanted to give a brief update on our Environmental Health Action Committee's focus for the year. The milieu in which we all live, work, play, grow influences our health in so many different ways. And environmental health is truly health. But we wanted to focus this year not on everything, but specifically on environmental justice and essentially the disparate and inequitable access that folks have to the benefits and burdens of the environment. So we just wanted to kind of give you guys an update. We're going to be focusing this year on environmental justice. It links to so many different topics. All the topics that we discussed today: health equity, COVID, reproductive justice, generally racism, environmental justice is all of these things. And wanted to give you guys a few ideas of how you can take action today to support our future peace. So firstly, we really wanted to say, join our action committee. We're one of the newest action committees we were established last year, and we would love to get new members aboard. So if you have any interest in joining our mission and our vision, we'd love to have you involved. And then also advocating for environmental health and environmental justice within your own local AMSA chapter. We're doing a lot on Instagram, and we're going to be doing a lot more in the next few town halls, and we're going to be sending you guys a lot more information in the future. So just keep your eyes out on what our committee is doing, and then also consider signing the SNMA's petition for racial justice and academic medicine and research. And then just as Dr. Patel kept saying, top line item is vote in November. Consider the environment this November when you guys are voting. So thank you for letting me give you a brief update, and on to the next updates from the next committees. Thanks.
And I think that's a perfect segue. We've talked so much during this town hall about the importance of voting, and that's why we have the Met Out the Vote initiative taking place here with AMSA that's partnering with VoteER to make sure we're promoting voting with our colleagues and for our patients. I'm going to turn this over to Jess to talk some more about Met Out the Vote.
Yeah. Hey everyone. So we have met out the vote going underway. We, as Ali said, we have partnered with VoteER, and we're really looking forward to kicking off Civic Health Month that starts in March. In particular, we have already started a competition with between Duke and UNC currently, and starting in August, we're going to extend that competition to all med schools across the country. We have the ability to, for each school to order their own bulk kit. I'll put the link in the group chat just now. So if you want to order a kit that's specific to your school, then that allows us to track how many voter registrations your school has actually gotten, which is a really cool feature. With COVID-19, voter registration is significantly down this year, and hospitals are actually legally, since 1993, able to be designated as voter registration sites along with the DMV. So it's really important that we in hospitals help make sure that our patients have a safe way to vote, and do that in a nonpartisan way. Being in North Carolina, we've run into some problems with concerns about partisanship, but overall, voter registration is a civic duty. Yes, there was just a New York Times article out about our initiative just yesterday, I think, or maybe today. That was really great. And so if you have any questions, please contact us at team@metoutthevote.org. That's the best email to contact us at. If you want to get involved, we'd love to get as many schools as we can competing. Again, the point is not necessarily the competition, but just to kind of spin off of the med student type A type personality. But really at the end of the day, we're just trying to get as many students and as many patients and as many people registered to vote as we possibly can, and get them access to their absentee ballots as well. So.
Ali, you're muted.
Apologies. Thank you so much, Jess. Once again, that's team@metoutthevote.org for anyone who's interested in getting people registered to vote. And there's a whole team ready to get you plugged in there. Next up, I'm going to turn this over to Becky to discuss a little bit about the Reproductive Health Institute and some programs coming up.
Wait, there we are. Thank you, Ali. Hello, everyone. We really appreciate people turning out here today. Aaliyah has talked about a lot of the components of our reproductive health project. The career pathways in family planning leadership program and the reproductive justice program both have begun, and we do have waiting lists up that you can check that out. And then we have our event coming up here in August on the 13th and 14th that we hope that you all will check out. And as we head into this coming year, we'll be having several more programs that will be launching related to the Reproductive Health Project. So stay tuned to hear more about that soon.
Thank you, Becky. And lastly, we have the Healthcare for All campaign, discussing what are some action steps you can take next. Just checking in here. If not, then I can do a quick screen share and talk about some of our efforts here. So generally, we talked about all the different calls to action. There's so many issues that we can be working on. So we've talked about the anniversary of Medicare and Medicaid on July 30th taking place, and about how key healthcare safety net programs along with the Affordable Care Act in our country are implicated here. And so we'd like to invite you to join us in action to protect and expand these vital programs. So you can find some more resources for these programs here on AMSA's website. I'll just pull this up right here. So if you go to amsa.org and if you go on the advocacy/healthcare page, we've put together a bunch of different resources. Some of these include specific to how we can focus on Medicaid expansion. We have a 2020 Medicaid expansion toolkit ready here for you. And then also we have general toolkits available for how you can be getting in touch with your members of Congress. So if you're interested in Medicaid expansion, or if it's the COVID care relief packages that we're advocating for, or the many different other issues that we're all that are important to us that we want to work for, some of these tools can apply for them as well. But especially in marking the anniversary of Medicare and Medicaid, some of our focus here today is on Medicaid expansion. So do make sure to check that out on AMSA's website. Also, for any of the different committees that you heard from today, if you're interested in getting involved with them, you can also go onto AMSA's website, go to Get Involved, and click on some of the action committees or campaigns or initiatives, and from there be able to get in touch with them and get involved there. So with that, we'll just open this up for any closing remarks from our speakers, Dr. Patel, Dr. Henry, Dr. Runyon, if you have any other final comments before we wrap this up here. No problem if you don't, but we'll just go ahead and go from here. I want to give a big thank you to our speakers, Dr. Patel, Dr. Runyon, Dr. Henry, for taking out the time and speaking to us here on this hot Sunday. And thank you to all the national leaders who presented and prepared for, provided questions and presented on some of the updates. And thank you for everyone attending here and for submitting some of your questions. We'll be posting this content over to all the different platforms. And with that, we'll hope you all enjoy the rest of your weekend. Okay. Have a good night, everyone.
Thanks, everyone.
Bye.